Hello, everyone. My name is Michael Cherry. I'm with the Division of Workforce Development and the Residency Program Director for CDC's Preventive Medicine Residency Program and Fellowship. Please welcome everyone to CDC's Preventive Medicine Grand Rounds for December 6th, 2023. The topic is Zero Suicide Through a Public Health Approach. Information about closed captioning and continuing education credits will be put available into the chat and continuing education will be made available through the CDC's TCEO continuing education software system. Today's speakers for this grand round are Diane Kaulen and Angie Cumming. Ms. Collins is a certified child life specialist and the Senior Community Initiatives Coordinator at Texas Children's Hospital. And Dr. Cumming is an assistant professor at Baylor College of Medicine. During this presentation, they will share research, experiences, and lessons learned while planning and implementing zero suicide. And I'm going to now turn it over to our speakers.
All right, thank you so much, Dr. Cherry. It is truly an honor and a pleasure to be here with all of you today to talk about coordinated suicide prevention efforts across Texas Children's Hospital in Houston, Texas. I'm Angie Cumming. I'm research faculty in the Division of Public Health Pediatrics at Baylor College of Medicine and Texas Children's Hospital. And I have the honor and privilege to work alongside and co-present today with Diane Kaulen, our Senior Community Initiatives Coordinator in the Division of Public Health Pediatrics. And I do want to note before we get started that this can be a really difficult topic, and we do want you to honor and take care of yourself. So if at any time during the presentation you need to step away, please do so and be sure that you are taking care of yourself. Next slide, please. So we have no disclosures to share with you today. And so for today's presentation, we do have 3 learning objectives. Those are to outline the steps implemented at Texas Children's for suicide prevention, summarize how zero suicide can be implemented from a public health perspective, and finally, describe the process used to identify and develop needed resources and disseminate them throughout a large organization. So just to introduce our system here, again, we're with Texas Children's System in the greater Houston area and Southeast Texas, also expanding to Central Texas, the Austin area. And our system is the largest women's and pediatric system in the nation. We have been up and running since the 1950s, and currently we do have 3 freestanding hospitals. One is also under construction in the Austin area. We have 9 specialty care locations, 12 urgent care locations, and then 67 pediatrics, so pediatric primary care clinics spread throughout the community. So, all right. And we would like to start today by acknowledging the many, many individuals who have participated in and made this work possible. Specifically, this work would not have been possible without the support of the executive leadership team, a motivated organization across the board, and countless hours from providers and staff across Texas Children's, across our entire system. And I also forgot on the slide before that, we also have a health plan. So my apologies for that. But we could not have accomplished this work without everyone who has been involved. And so Diane and I are the speakers today, but we do want to acknowledge that this is the effort of a large number of people. But I do want to acknowledge the leadership and organization and drive of Diane Kaulen, as she was instrumental in moving this work forward. And you all will have the honor of hearing from her shortly. So we'd like to get started with some background information that unfortunately you are probably familiar with. This slide reflects data over a 10-year period, so from 2012 through 2021, inclusive of those years, and shows that suicide is the 2nd leading cause of death for youth and young adults ages 10 to 24 years. And this is behind the leading cause of death, that is unintentional injury. So For children 5 to 9 years old, the numbers are small and they are considered unstable. But in 2020, suicide came onto the list as the 10th leading cause of death for children 5 to 9 years old. Next slide, please. Okay, so the actual number of suicide deaths has increased over the last decade, and so has the rate of suicide deaths. And so this graph here shows the rate of suicide deaths per 100,000 children by age group. So the darker maroonish line that is the higher of the two represents youth 15 to 19 years old and illustrates that the rate of suicide deaths has increased from 7.5 to 10.6 suicide deaths per 100,000 youth from 2010 to 2020. Among our younger youth, the 10 to 14-year-old group, that's the brighter red line that's lower on the graph, the rate has more than doubled from 1.3 to 2.8 suicide deaths per 100,000 children over this time period. And then if we want to look beyond 2020, that you have to look at the provisional data. So the provisional data that's available through CDC Wonder does provide aggregate data from 2018 to 2021. So this is a 4-year period. And according to the provisional data for the 10 to 14-year-old age range, the suicide rate remains at 2.8 deaths per 100,000, but for the 15 to 19-year-olds, this combined rate increased slightly to 10.8 per 100,000 youth in that age group, if you're wondering about more recent years. So as with many other outcomes in healthcare and in public health, we do see differences when we examine our data by race and ethnicity. And so when we stratify the data, you can see the suicide death rate among youth 10 to 19 years old. You can see those rates here by race. And for the American Indian and Alaska Native group, the rate of suicide death ranges from 16 to 24 in this time period, from 2015 to 2020. So that's the highest line on the graph. That is followed by white youth, who have the next highest rate that ranged from 7 to 8.5 deaths per 100,000 youth. And then you may also notice that the rate among the white youth has slightly decreased in recent years, while the rate for Black and Hispanic youth has increased, and that for Asian youth has remained fairly constant since 2016. Okay, so far we've described what suicide deaths have looked like over time, but we also know that there are even more children and youth out there who experience suicidal thoughts and behaviors. And so one way that we learn more about the youth is through the Youth Behavior Risk Surveillance Survey. Many of you know, I'm sure, that this is a survey conducted through the CDC among high school students across the United States. And students are asked to complete surveys and respond to health behavior questions, including 3 questions related to suicidal thoughts and behaviors. So the most recent survey was conducted in 2021, and our youth responded that 22% of them had seriously considered attempting suicide in the last 12 months. 18% had made a suicide plan, and 10% had actually attempted suicide in the last year. So given our work, given that our work is in Houston, we are fortunate in that the YRBS, we do have local data as well. So that is displayed on the slide. And you can see that in the Houston area, our results are pretty similar. So slightly lower prevalence of seriously considering a suicide attempt and a slightly higher prevalence of actually attempting a suicide, but pretty similar to the national figures. And these figures here in and of themselves are very striking, and they do reflect an increase in these thoughts and behaviors over recent years. But these are aggregate, and just like in the deaths, we do see differences by particular subgroups when we stratify our data. It's no different here. And so these outcomes are experienced even to a greater extent among female students, Black students, our LGBTQIA plus students, and students who had same-sex partners. And as an example, among the children who made a suicide plan, or excuse me, among the LGBTQ plus population that answered this survey, 37% said that they had made a suicide plan in the last year. So these aren't small differences that that these youth are experiencing. So we do want to keep that in mind. And so in December of 2021, we had, as I've shown you, all of these increases over time in deaths, increases in suicidal thoughts and behaviors. The Surgeon General actually warned of a youth mental health crisis. And you may have seen the even more recent advisory that was put out earlier this year, in which he warned that, quote, there is growing evidence that social media use is associated with harm to young people's mental health. I think that that's something that we all maybe suspected, but now we're getting the data to actually support that. So as a healthcare system focused on serving children and youth and their families, we were feeling this too. This wasn't just something that was, abstract happening to other people. We're feeling it too, and we wanted to proactively respond to children who are experiencing suicidal thoughts and behaviors and prevent others from developing them. So to respond to this mental health crisis locally, we applied a public health framework to guide our work. And we started with an informal needs assessment to define and assess multiple communities within our own system. We identified ongoing work and determined what else needed to be done. We then quantified the issue within our own system and at the county level. We developed multiple work groups, each of whom created charters, goals, and timelines to address this issue from multiple fronts. And we identified areas for and conducted research. We prioritized needs and developed action plans. We implemented the action plan, and we have implemented a dashboard to monitor what is happening across the system. And that's why we're here today. So in this presentation, we're going to take you through the steps that have been taken from assessing the needs and quantifying the problem within our own system to the development and implementation of these work groups to both expand ongoing efforts and develop new initiatives to expand staff training, services, and supports in response to youth suicide. And I just want to make a note that the work we are about to describe took place over the course of about 13 months. So in 2021, we started with a scan of the literature and expert opinion to outline actions that were ongoing, as well as opportunities to expand efforts along the suicide prevention continuum, from those upstream efforts where we're building protective factors to the downstream factors where we're actually responding to and providing post-vention services. And we know that suicidality is an important issue within our own system, and we do have that healthcare focus, but we also know that the work of prevention and response goes beyond our system. So it's going to be important for us to partner with others. So the items in green on this chart were things that were already happening. And so you can see that we did have work going on across the continuum. This included programs to prevent adverse childhood experiences. And then in that middle section, we had the most going on, of course, where we were conducting regular screenings, providing referrals to care, and providing treatment for children who were in our care. And then moving all the way to the post-vention side, there's a member of our team actually that leads the child fatality review team for the county. So through this process, we were heartened to identify, all of the work that was going on, but we also, identified several opportunities for us to expand our work and care further for these children, their families, as well as our own providers and staff. And we're going to talk more about these efforts in future slides. So in the previous slide, I mentioned our efforts to quantify the issue locally and the child fatality review team. So the CFRT, as we refer to them, is a multidisciplinary team made up of professionals and community members representing various sectors, including but not limited to healthcare, behavioral health, injury and violence prevention, emergency services, law enforcement, the medical examiner's office, early childhood, consumer safety, public health, and others. And this team meets on a regular basis and reviews all non-natural child deaths in the county. And as a result of all of this work, they did publish a decade report in 2020. And so this was for the years 2008 to 2017. And when we go to this report and we look specifically at deaths by suicide, we see that the rate of deaths per 100,000 children has increased over time from approximately 3 per 100,000 in 2008, all the way up to almost or just over 5 per 100,000 in 2017. And this represents a 70% increase in child and adolescent suicide in Harris County. And when, again, looking at our more local data, our local epidemiology does reflect national trends in that males are more likely to die by suicide than their female counterparts. And in Harris County, over 70% of our suicide deaths were among males. And then when we stratified our local data by race, we do see disproportionality between the child population in Harris County and the child suicide deaths by race and ethnicity. So most notably, you may see that there is a higher proportion of suicide deaths among white children when compared to the overall population, and a lower proportion of suicide deaths among Hispanic children compared to the population. And we also stratified our data by age, and similar to national patterns in Harris County, more suicide deaths are among our older youth. Over 60% of the youth who died by suicide from 2008 to 2017 were 16 and 17 years old at the time of their death. And I would also like to note that the approximately 25% of deaths among children 14 and younger, so a quarter of these deaths were also among children 14 and under, before most children even enter high school. And so we have the national data, we have the county level data, but we wanted to look even further. And while we know that the child fatality review data gave us a lot of information around who actually died, just like the YRBS, we wanted to know more about what was happening in our own system before a death. So where were we seeing these children in our healthcare system? And what we saw, and as I'm sure you suspect or you're feeling in your own practice, is that again, our data reflect these national trends, and that over the last 20 years or so, we have seen an increase in the number of encounters with an ICD-9 or an ICD-10 diagnosis code of suicidal ideation. So that's sort of the reddish orange line that's the highest there. Suicide attempts, that one is the yellowish brown line along the lowest line. And then self-injury, encounters with self-injury diagnoses are represented by the green line on this graph. And you can see that they are all increasing. And I would like to note that they are all increasing before 2020, before COVID, but these were already on the rise. And then to provide some context about what was happening broadly over these last, 2 decades or so since the year 2000, we've noted some key events on the figure. And I do want to note, this is for historical context only. We are not suggesting causation or even correlation. There are studies coming out, and we will look more at those, like the one I referenced earlier. But this is not based on our data. This is to provide historical context. So you can see here social media coming onto the scene with Facebook in 2005, and then they expanded to a more general audience. They first started, you had to have a .edu email address, if you'll recall. I'm probably dating myself. But then we went to, anyone who was 13 years and older could open a Facebook account. Also in 2006, we started tweeting on Twitter. Then along came Instagram in 2010, then Snapchat in 2011, and TikTok came onto the scene in 2016. And in 2018, TikTok was the most downloaded app in the United States. That was a fun fact I did not know. So in addition to social media coming onto the scene and changing the way we interact with one another, there was also a transition from ICD-9 to ICD-10. So perhaps providing a little more nuance into our diagnoses. In 2016, our Texas Children's primary care clinic started implementing universal mental health screening with children 11 and older. In 2017, our emergency center implemented universal suicide screening. In addition, the Netflix series 13 Reasons was released. In 2019, we had the Joint Commission release its requirement for suicide screening for children 12 and above who were seen for a mental health reason. And then, of course, in 2020, no one needs me to, tell you that that's when we experienced the onset of the COVID-19 pandemic, but that's when we were experiencing shutdowns, remote school, et cetera. So a lot has happened during this period of time. And I mentioned on the previous slide that we started screening our patients who were 11 and older. But then we took a deeper dive and we could see that our patients were struggling before we were even formally screening. So on this slide, you can see an increase in the number of encounters with a diagnosis of suicidal ideation, suicide attempt, and self-injury for our 5 to 10-year-old patients in recent years. So again, this increase before COVID, and these are kiddos that we are not, were not at the time and probably still are not due to their age screening regularly. So then we have all this data at our hands. So next we wanted to triangulate what we have, everything that we have access to, and see if there was even more to the story. So we looked back at the data from the Harris County Child Fatality Review Team, and we conducted a chart review to see who had been seen within our system prior to their death. And we found that for the children who died in 2021, over half of these youth who had died by suicide in 2021 had been seen in our system within 5 years of their death. Almost a third of these children had been seen in our system within 1 year of their death, and a quarter of them had been seen in our system within 3 months of their death. And, we want to note that the majority were actually seen in primary care. Some were also seen in specialty care, but these were not necessarily children coming into our emergency center in crisis. It wasn't the picture that you get in your mind. Also, screening for depression did not necessarily identify suicide risk in these youth in the year or even in the months before their death by suicide. So these findings were incredibly sobering for us, and we knew that we needed to act. And so, given this landscape, after assessing all of our existing efforts along the suicide continuum of care, quantifying the issue nationally and locally, internally. It was clear that we had practices and initiatives in place, but there was also room to do more. And so building upon existing partnerships with psychiatry and psychology, we gathered a team of providers and subject matter experts to discuss all of the data we had collected, reviewed, and analyzed. And we asked some really thoughtful questions about what we were already doing, what we needed to do, and what it was that we needed to do the other things we needed to do, right? So what resources did we need to fill in the gaps and move forward and make sure that we are doing those things well? So that was a very long buildup. There was a lot of background information. I promised you at the beginning that we would tell you what we actually did. So the rest of this presentation will be dedicated to just that. So in October of 2021, we developed and proposed a committee structure to the Behavioral Health Executive Steering Team. And we became a part of a larger ongoing initiative to expand behavioral health care and services in our system. And I do want to stress that this was ongoing, and we were able to join in that effort. So we didn't start the expansion of behavioral health care in our system because you could see from the years and years before, we knew that there was a need. But through this work, suicide response and prevention became a bigger part of that conversation and the planning process. So in November of 2021, the committee structure depicted on this slide was presented to and approved by the executive steering team. And collectively, these committees were called the Suicide Response and Prevention Work Group. So by January of 2020, our committee chairs had been identified. In February of 2022, committees began meeting. Each committee developed a charter and set goals to accomplish over the next 6 to 12 months. And then going back to that public health framework, these work groups were formed in response to the system issuing a statement that we are poised to be a part of the solution. And we needed to act both internally and externally with other entities in the community. And these work groups were the structure through which we searched and summarized the literature and identified ongoing efforts more specifically and developed priorities for moving forward. So I mentioned that we became a part of the behavioral health expansion in our system, and you can see the suicide response and prevention work groups were adopted by the Behavioral Health Task Force and given a spot with other very important initiatives that were going on, such as expanding behavioral health inpatient units, the behavioral health support team, developing the intensive outpatient program, and strengthening behavioral health in the emergency center. This task force adopted the suicide response and prevention work groups at approximately the same time they were launching their initiative to further develop and expand integrated behavioral health across our behavioral health clinics. So we were, the system was primed and was ready for this. And so the timing was great. And so now we're going to talk a little bit about each of these committees. So the research committee was comprised of an interdisciplinary group of leaders and researchers across Texas Children's. We conducted a scoping review of the gray literature to identify tools and resources available for providers and identified suicide-related funding opportunities. The main activity that I would like to highlight from this group is our participation in the Baylor College of Medicine Datathon. So we conducted a study of mental health screenings during well child checks during our primary care clinics. And in this study, we calculated the prevalence of behavioral health screenings that were completed in the well child checks, described the distribution of the screening scores, and then we described the distribution of the screening scores specifically among patients who had this well child check, were screened, and within the year after that well child check received a suicide-related diagnosis. And so for today, we'll be focusing on aims 1 and 3 to share with you. So we used Slicer Dicer in Epic to build a visit model and identify behavioral health screens. So in this figure, you can see that the blue bars represent the number of well-child checks done in primary care from 2016 to 2021 for children who are 12 to 18 years. The orange and yellow bars represent the number of patient health questionnaire screeners and pediatric symptom checklist screenings that were conducted. So the orange bars are for the PHQ-9 and the yellow bars are for the PSC-17. And you can see that over time, the PHQ-9 became the dominant screening tool used. And the gray line along the top represents the percent of well-child checks in which a PHQ-9 screener was done. So since 2017, 90 to 95% of our well-child checks have included a PHQ-9 screening. So this is great. We were aiming for screening everyone, and we were very, very close to that. And so if we look a little bit further, though, this graph shows data for children who had a well-child check and then received a suicide-related diagnosis up to 1 year following that well-child check. So those dark brownish bars represent the number of children that had an elevated PHQ-9 score, so based on their total score at their well-child check. And then the lighter tannish bars represent those who had a positive response to question 9. And if you're not familiar with Question 9, it is in the last 2 weeks, how often have you been bothered by thoughts that you would be better off dead or thoughts of hurting yourself in some way? So then the green line represents the number of children who were diagnosed with suicidal ideation, and the yellow line kind of toward the bottom there represents the number of children with a suicide attempt in that year following their well-child check. So we're still digging further into this data. We're learning more about these patients, but in this initial look, the differences in the PHQ-9 scores and the positive response to question 9 and the number of patients who were then diagnosed with suicidal ideation in particular is striking. So in any given year, no more than 31% of patients who had a suicide-related diagnosis also had a positive PHQ-9 screen at their well-child check. So although we were doing what we were supposed to be doing, the screening tool didn't always allow us to identify children who would go on to develop suicidal thoughts and behaviors over the next 12 months. So I will stop there. That is the work of our first committee, and I will turn the presentation over to Diane, who is going to describe the work done through the other 5 committees.
Thank you, Angie, for that overview and leading these efforts around data collection and research. You've been a great partner and mentor. Next, I would like to highlight the work of the following 5 work groups and some of our future plans around suicide care and prevention. Our training committee's first action was to collect information around the various trainings that are available, not only for community-based education on suicide prevention, but also the very therapeutic training programs, like what is the cost, what is the process, how many hours does that take, which we then shared with our mental health leaders. But in September, we skipped, in September 2022, for our Suicide Prevention Month, we created a suicide gatekeeper training that we launched at that time. And we did that through our virtual continuing education platform. We wanted to highlight this education as it would provide an understanding of warning signs of suicide, appropriate language to use, steps to take if we were concerned about somebody with suicide. We wanted all our staff to understand that framework that would assist them if they had a perspective of if there was a patient or family, if they were concerned about a coworker that was had suicidal concerns, and if they were in the community and they were with their families and friends, and if they were concerned about somebody with suicide. We know that our Texas Children's Hospital, Baylor College of Medicine families or staff members are well seen within the community and often are approached to say like, oh, I'm concerned about my child, what should I do? And we really wanted to make sure our staff had all of those tools, no matter where they were. To help with this communication and reinforce the message and the importance of becoming educated, a video message from our executive vice president and our chief of psychology was sent through a global alert to all employees within the organization. Also included in this global email was information around the Zero Suicide Framework and an invitation for employees to become engaged. In the first 3 months of the launch, we had around 65% of the TCH-BCM workforce take this training. 88% of the individuals who took this survey stated they felt this training helped provide them more knowledge around suicide awareness, and they felt better prepared to address these concerns. This training continues to be available through our Voyager system and is encouraged for all new employees. We also received feedback from our employees who took this training, highlighting the impact it was really making real time. One employee expressed how thankful she was when we included information about those who lost someone to suicide, and how this training provided her, as a survivor of suicide, some opportunities for healing. Another person recognized that many of the warning signs aligned with her daughter's recent behaviors. She paused the training and immediately reached out to her. She stated that this training may have saved her life. Another employee highlighted how much this training helped them realize how much they were personally struggling, and it was a turning point for them getting help. While another employee expressed gratitude as when they had a family member call, they had the tools to help. This is such a great illustration of how you never know when you can save a life. Our next committee was our internal response group, and they focused on our workforce. Based on the feedback we received, we focused our efforts in two main areas. We identified the process for which when an employee is struggling with a suicide-related concern, whether that be personally, whether it be for a family member, or whether it was in generally suicide loss. Although our organization had a process in place, many leaders were struggling to know where to look for that process and how properly to support our workforce that was really truly made up of faculties, learners, and staff from multiple organizations. These leaders also verbalized that they received this information when they were new to their position, but it would be helpful to be able to return to these resources later and better understand their role within this when a situation arises. Our second goal was to identify how we can better support our employees following the loss of a patient to suicide. We wanted to ensure thoughtfulness on how we informed our medical team that they had a patient who took their own life. As many of you all know, all of us who cared for an individual who eventually died of suicide live with survivor's guilt. A medical team is no different. They live with that guilt, and they deserve the care and the support through that process. In this work, we created several workflows outlining these processes and then posted them in a centralized location, which we will discuss later. Our Family Response Committee focused on the care we provided our families. We started this group within the intention of how do we better support those families who lost a child to suicide? But through our beginning discussions, our goals became much broader. We soon realized that in order to support our patients and their families, our staff needed to be in a place of comfort when addressing these situations, and they needed the resources to provide that care. So we began to gather information from our employees on challenging situations they encountered and what they needed to provide better care. We then examined resources that we felt was beneficial for our staff to be able to share with patients and families. So we sent out a survey and were surprised when we obtained over 200 responses from frontline clinical staff members. Of those who completed the survey, we learned that only about half of our clinical staff truly felt comfortable working with this population. As we moved in the comments, we began to see really truly common themes. Our staff identified a lack of quality resources that they needed to support families and really support them where those families were at the moment and help them find that access to care. Staff verbalized that they wanted more trainings to navigate specific practices and challenging populations. They discussed the struggle they'd encountered navigating parents and patients' concerns, and that some of them were here, especially some of the comments that they were hearing from these patients. Patients often find someone that they can trust to share information to, and oftentimes that person that they were communicating with is not the person in our organization that is identified to navigate those concerns. So it would be like a patient saying something to their sitter who isn't qualified to talk about maybe abuse situations versus a social worker. Staff also verbalized the challenges between finding balance between the various roles they provide and the lack of awareness of that expansion work happening in the hospital. Many felt that they were working in this challenging space with possibly no relief in sight. So our team began to look at all the available suicide-related resources that were currently available around the nation. We identified many resources that we felt were high quality and met the needs of our patients. But oftentimes we found there was a lack of resources around key areas. So we began and worked with our clinical experts, as well as we brought in family advisors to create TCH branded documents to meet those needs. I truly cannot underscore the importance of involving family advisors into this work. They provided a great deal of insight to what the true needs of families are. So included in our new documents is a parent's guide to SOC hospitals, list of resources and definition of those resources, a quick guide for parents who need to talk to their children about suicide, including age-specific language. All of our resources were available in English and Spanish and for our Houston and Austin communities. Currently, these documents are stored in a centralized location, but will be coming soon to our external TCH site. Our next committee looked at the needs of our community to better understand how TCH can support. We interviewed around 15 organizations, including schools, healthcare clinics, and social service agencies. We asked about what are their available resources, what are some barriers to care, and what is their biggest need, and how can TCH help? The four main themes that came out of these interviews were not surprising, as it highlighted the growing need of mental health resources. But some of the softer comments really did stand out to us. Like, how many agencies did not have a plan for what to do if one of their employees were struggling with suicide? How many organizations working with youth have seen a significant increase of youth struggling with homicidal ideation? And a police chief in a rural community saying, I don't think I should participate in this survey, because if we were called for a child with suicide, we would just call CPS. Overall, what our community asked for us was more training to prepare parents and professionals. Many schools stated that they provide information sessions to parents around getting your child into college, and they had a packed room. But if they provided information around mental health, no one showed. Their hope was that if TCH came out, maybe, just maybe, they would come. But overall, they said most importantly, the community, they need TCH to increase mental health services. And our last work group focused on bringing the Zero Suicide Framework to Texas Children's. Zero Suicide is a transformational framework to guide healthcare systems to provide safer suicide care. The Zero Suicide Framework, although somewhat aspirational, focuses on the belief that all suicides can be preventable. Aligning with national data and our own organizational data, we know that individuals who are struggling with suicide thoughts are entering into medical environments within the weeks and the months prior to their death. As someone who started as a direct patient care provider to becoming a leader of frontline staff, what I really appreciate most about the Zero Suicide Framework is it's not just another initiative that staff have to do. There's a huge focus on ensuring that our staff have the tools and resources that they need to be effective. So since our organization was already going through many aspects of expanding access through our executive behavioral health work groups, our team was really able to focus on the process that we needed to do and the focus of our frontline staff. One of our first tasks was completing an organizational self-assessment. We had team members from various areas of our organization, from our urgent cares to HRs to Pavilion for Women, which is our department that provides maternity care, to our clinical care and more. They were all rated our organization using the Zero Suicide Organizational Self-Assessment Questionnaire. Each team that completed the survey included frontline staff all the way to organizational leaders. And together they met and came with consensus on how they were going to rate our organization in various areas and what comments they wanted to provide. An enormous amount of information was gathered from the survey that we were able to officially kind of organize into 4 main buckets. These areas of focus on how we needed to bring a broader full scope look to the patient populations, as too often our departments tended to work in silos. We saw a need to ensure we are investing in our workforce, not only because many of the staff were navigating this mental health crisis at work, but they were also navigating it at home within their families and within their communities. This is a delicate patient population with many additional complexities or life experiences that played into their current situation. Therefore, our staff in all areas of our organization were thirsty to understand these complexities and how to best support them. The survey also focused on that although this was a huge focus of our organization, our executives were working long hours and dedicating so much time to behavioral health. Oftentimes our frontline staff were not fully aware of these efforts. My biggest takeaway from the survey was that we all know there is not enough mental health providers available to meet the needs of everyone who is desperate for care. And so often we move forward with organizational efforts, pulling them as consultants versus pulling them into every single conversation. However, I believe it is important for them to be integrated into every aspect of this work. They are able to help bring clear understanding of best practices and all the numerous different types of terminology. So as we move forward, we wanted to ensure that these were efforts led by our mental health providers who had the knowledge to ensure that we were not only implementing best practices, but we were able to give the reasons why and be able to communicate that throughout the process. Our next step was to roll out by bringing in the Zero Suicide Educational Development Center to Texas Children's Hospital for an organizational Zero Suicide Academy. For this academy, we had 16 teams with at least 4 members per team, and a total of 84 staff members take part in a 2-day training around best practices in suicide care. This 2-day session allowed us to have focused time to bring high amounts of energy to addressing this topic, get everyone on the same page, as well as provide time to have some really rich conversation. Zero Suicide has 5 levels of care, and our theme throughout the 2 days was Strive for 5. From the academy, we pulled out various themes from our action plans, post-session surveys, and transcripts. As a reinforcement of these themes, we continue to see some consistent areas of focus as we did in all the other surveys. Following the academy, each team was required to create some action plans. And so over the next coming months, each team and I worked on those action plans and figured out how we can best implement those plans throughout their areas. And all of these plans were unique and different to each area within the organization. The final component of Zero Suicide launch was the Community of Practice program. The typical approach during this phase was to take each component of their framework and create a timeline in which our organization can roll out each element. But as we began to align these elements to the work already occurring within our organization, I took note on how many of these elements we were already working on in our other executive work groups that we highlighted at the beginning of this presentation. And what I firmly knew was that there was not a single leader in our organization that had the capacity to sit in a meeting discussing the exact same thing that they were discussing in the previous meeting. So we decided we needed to look at this differently. As an initial brainstorming exercise with leadership, I asked, when we discuss your suicide, what have you been most surprised about or most excited about? Hands down, the number one answer was, we love the passion and the grassroots efforts of our staff. So we began to look at ways we can better continue to further that drive and that energy of our staff. We went back to our surveys and the statements that were continually put throughout these surveys and focused in those specific areas. We then teamed up with Zero Suicide and created a plan that supported the needs of our workforce. Trainings continue to be a focus of our frontline staff. So we chose specific training needs based on the staff surveys, and Zero Suicide agreed to provide those trainings. So we developed these 6 virtual trainings that focus on the most common questions staff were struggling with, like how do we better support our perinatal and postpartum women? What are the nuances of working with children with intellectual disabilities and or autism and suicidality? We are in an acute care setting, and how do we better support these patients as they wait here for sometimes weeks as they waiting for a psychiatric hospitalization? How do we recognize and support mental health concerns in a non-behavioral health specialty care clinic? As we follow up with these families, what do we say and how do we navigate these situations? And really kind of help all the staff understand what's the difference between a mild and moderate high-risk patient, and what do these levels mean, and how does this change the treatment plans? We had these, as I said before, these trainings were offered live, but we were able to record them, and we have them in a central location for our teams to go back to and watch. So as we began throughout this year process and began to develop these work groups, more work kind of came up as highlighting the need for different areas of focus. Since we are an acute hospital, we wanted to ensure that we were properly educating leaders and frontline staff on the elements of suicide care. As I mentioned, we are an acute care hospital, and many of our staff did not have a full awareness of what we as an organization, and specifically an acute care organization, can do prior to transitioning families to the next level of care. So we created our 6 steps to suicide care and provided education. Those 6 steps, meaning screening and assessment, really highlighting what the differences of those 2 elements are, as were often interchanged. We wanted staff to understand the importance of creating a safety plan, providing counseling for access to lethal means, that these children were not coming in here into the hospital under crisis, that they were part of a larger family system, and sometimes that family needed help. And we needed to provide some strong care coordination so that they were able to get to that next level of care. So in these trainings that we provided, we included families with lived experiences to help highlight from a personal side why each of these elements were so important and how they can be implemented throughout our system. But in our education, we reinforce that this isn't just strategies that are implemented at one time, but there is a broader view to this care. And if we're really going to impact suicide prevention, we need to support children where they were. So when they left our hospitals, they go home, they go into schools, and we needed to find avenues to better collaborate and better support children where they are. And so this roadmap became a guide for our, what we now call our current system of care team that we are currently piloting. So we started this team. We are currently starting this team in our emergency centers and really focusing on that area because this is where the most critical and our highest volumes are. With this team, we are incorporating behavioral health clinicians into those emergency areas to work with children and families as soon as a child screens positive for suicide. These clinicians complete this suicide assessment. They create a safety plan, provide family supports, and provide some lethal means counseling. We then also have psychiatric support to help navigate medication needs of that child. Together, the behavioral health clinician, the psychiatrist, and the medical providers determine the appropriate next level of care. From there, we ensure that families are getting into the next level care, and we are providing that needed follow-up support. In addition, we are working with our community partners to navigate how best to expand services into the community. In addition to our system of care team, we began to really look at our system as a whole and decided we needed to streamline our data. So we created a specific quality improvement team that focused on our national safety goals. Our first step was to create a crosswalk that highlighted the requirements of our various reporting agencies and our ultimate goal, zero suicide. We then created a universal definition and measurement that would be used across the system. And then lastly, we created a dashboard that can measure our suicide prevention efforts in each area of our organization. So we can see a broad view as well down to the intricate data of every patient and every unit. We have to highlight the immense amount of work that this included. It was not only just creating this dashboard, but it required a lot of change and vulnerability from our leaders. It also included creating a significant amount of new Epic builds and then changes to that process, as well as educating staff on those changes and their willingness to adapt to those changes. This really was a huge undertaking. As we move forward, this committee is now transitioning to organizational leaders who will begin to meet regularly to examine this data and make suggestions for improvement. From a public health framework, we are able to use this data to identify patient populations who are at the greatest need and target more of those suicide prevention efforts into the community. And lastly, the culmination of all our work led to the creation of a suicide prevention SharePoint site. As I mentioned throughout this organization, or through this presentation, we have placed our resources in a central location, and this is it. This is a site that's located in our internal intranet and is accessible to all employees. Within 3 clicks, staff are able to obtain resources around suicide loss, suicide attempt, mental health conversations, access to care for our patients and families. But also all this information is specifically designed so that they can access it for themselves. Through the clinical resource sections, our staff can access clinical resources, talking points, workflows, trainings, as well as what is all happening here within our organization around mental and behavioral health. And lastly, staff can pull different documents that would help our community. A lot of times we have organizations calling us saying, how do I navigate suicide, or what should I be doing, or what should I be thinking of? And so this site is full of those resources. The most amazing part of the SharePoint site was that it was mostly created through the dedication of our frontline staff. This is a great example of what can happen through the grassroots efforts. They were the ones who helped determine what was needed for the site, and they were the ones that helped us build it. For example, we had someone from the Treasury Department call us and say, I want to help. She had experience in building SharePoints with her team, and so that's how she helped us. So during her lunchtime, evenings, and weekends, she took our vision and made it all happen. Throughout the site, we have embarrassingly placed my photo all throughout. The purpose of this is so everyone knew that this site had an owner. We did not want the site to become quickly outdated, and then no one knew who to go to with or contact with concerns. We also wanted to make sure that if there was a document that staff needed and they didn't know where to find it, or it wasn't on there, they had someone to reach out to and ask for help. I have to say the biggest challenge right now is that ensuring everyone, and I mean everyone in our organization, knows about the site. We have found that we can tell people about the site, but the information can easily slip away from their memory as they don't understand the significance of it. But when we actually show the site, we hear comments like, "Oh, I never thought all of this would be here to help me," or "Wow, I keep thinking that about something else that could go on the site, but as you move forward, there it is." So as part of my role, I'm ensuring that I get to every department, every staff meeting, and spend time going over the content, as it truly does make a difference. We are able to track metrics on the site, and we can see daily visits that are increasing over time as we are able to train more locations. On the slide, I've also highlighted some of the feedback we received. But as we were developing the site, we wanted to ensure that staff were able to feel the energy and the support when they visited. So all the way throughout, we included quotes from staff, and each main page includes a video that addresses the content within that section. And at this time, I'd like to share with you our introductory video.
Together, we can save lives.
You are not alone.
Your actions can make a difference.
Every 26 seconds, someone attempts suicide. The words you say, the tone you use, and how you show up for someone in crisis could save their life.
Mental health is the connection between the mind and the body. It's the harmony between thoughts, actions, and behavior. And if we can help young people generate positive mental health, we can help them thrive.
At Texas Children's, we're working to lead a system-wide and organizational commitment to safer suicide care as we treat the mind, body, and soul.
Suicide is the second leading cause of death for adolescents and young adults aged 15 to 24.
If you've come to the Suicide Prevention SharePoint site, you may be looking for resources to better support a patient and their family. Maybe for yourself or a loved one. We are glad you're here. This site is full of resources, clinical trainings, tip sheets, and more as you navigate challenging conversations around suicide.
Texas Children's stands by zero suicide. You may be asking yourself, what does zero suicide mean, and how does it apply within Texas Children's? Well, we asked ourselves one question: how many suicides are acceptable at Texas Children's? And the answer was simple: 0. That's because suicide is preventable.
We all may know of someone struggling, and together we can change the outcome by leaning in and engaging the appropriate resources to find the proper help.
As a team, let's advance the conversation and our mission.
We all have a role to play. With your help, we can save lives.
I, like many others, have been affected by suicide, professionally and personally. And in pediatric healthcare, sometimes we get frustrated because we can't control and prevent everything. But suicide prevention is different. We can prevent it, and we must make a difference.
You are not alone. We are all in this together.
We're all in this together.
And I hope that that video can really just highlight the importance that we feel suicide prevention is and the true total commitment of our entire organization. And as Angie mentioned at the beginning of our training, our work is just a portion of the comprehensive work occurring at Texas Children's around mental health services. As you can see, we are expanding access through increasing our behavioral health beds, launching IOPs, and incorporating integrated medicine into our primary care clinics. But we also help behavioral health providers supporting our acute care floors as children are waiting for the next level of care. And we are redesigning our emergency centers to better accommodate to this population. And as our work groups have reached our goals, we have shifted our focus to the system of care team. A new project manager has been identified to work through the onboarding process of this team. And our current work groups are taking a back seat, but can arise again if a need occurs. As the hospital continues to grow and improve our suicide care internally, I have shifted a great deal of our work in the public health division to the community. We are grateful to live in a state that has a group that is actively working to bring together all of those individuals who work within suicide care and create a structure and provide support in community buildings. So one of our aspects in this work is to really connect and work with community partners. Some of our surrounding counties currently have coalitions of various sizes and various action plans, all of which we are integrated in. But unfortunately, there was no coalition in the Harris County. So we are partnering with various organizations within Houston and launching a sustainable coalition in the greater Houston area. And at this time, I will pass it back to Angie.
Thank you, Diane, both for sharing all the information about all this hard work and also for your dedication to leading it. And now we'd just like to share some of our lessons learned. So it's always hard to find the time to stop and reflect upon your work and really think about how things are going. But, preparing for this presentation actually allowed us to sit down and do just that. So we were able to compile a list of lessons learned throughout this entire process. And we categorized these lessons into things we learned about getting started, things we learned about navigating forward, and then we also had a list of surprising results. So the lessons learned about getting started included the need for, leadership buy-in and support. And, we absolutely had that from the get-go. So there was from the highest level, we had support from the get-go, and there were already some ongoing efforts, but they weren't necessarily coordinated across the system, and that support and buy-in made that possible. Next was the need to examine the organizational readiness. So, what is the landscape? You've got, national data about what local data are available to you, what internal data are available to you, what's happening within your organization, and what are your gaps. So you need to know about yourself and your own organization before you can really move forward. We also, learn to look toward our own clinical experts, and not that this is something that we don't do, but we did bring in Zero Suicide. We did bring in, an external entity to, consult and to guide us. But even through that effort, we were able to leverage our own internal expertise. Diane highlighted those 6 trainings that were provided through the Zero Suicide process that were very specific to us, and that was a collaboration with them, and some of our own providers really contributed to those conversations to make them as relevant as possible to our various staff and providers. The need to standardize definitions and data collection. This is up there with leadership buy-in and support. I mean, this is absolutely critical. And we spent hours upon hours over many, many months, discussing numerators and denominators, and, are we calculating our screening rate in the same way, for example? And that seems pretty straightforward, but who are you excluding? Why are you excluding them? So many, many conversations to make that dashboard come to life. And then finally, you really need to start internally before going externally. So think of this as, getting your house in order. So even though, to work up and down, along the entire suicide continuum, you do need external partners. You really need to know what it is that you're doing and what gaps you have so that you can be the best partner. What is it that you have to offer? And then what is it that you're looking for? Who do you need to complement the work that you're doing? Then the lessons we learned around navigating forward started with, integrate into existing organizational structure and initiatives if possible. So, the expansion of behavioral health was obviously happening, but it didn't quite have as much of a specific focus on suicide. And so that it was a natural fit, they were able to bring us in and get on board and be part of those thoughtful conversations so that, we're not just doing something a certain way because it's comfortable and it's the way that we've always been doing it. But if there's an existing structure and initiative that makes sense to join up with, to do it. So don't duplicate efforts if you can avoid it. Thinking about the size of your organization, you'll want to think ahead about your communication strategy. So again, we have 3 hospitals, 65 primary care clinics, specialty care clinics, a health plan, urgent care centers. And in all honesty, we are still communicating these efforts to our providers and staff. The SharePoint site is there, the videos are there, email newsletters have gone out, training notifications have gone out. But Diane is literally going on the road to our community-based primary care clinics as well to walk them through the SharePoint site and really have those conversations as well. And then thinking through the staffing allocation. So, as you expand services, who's going to do it? That's a real question. Is this something that can be, absorbed and integrated into existing workload, or do you need new folks? And then finally, philanthropic support. So, eventually you can bill for a lot of the clinical services that you're going to provide, but getting that stood up does take financial support. So, we are very grateful for our philanthropic partners who are helping this work move forward. And then finally, the surprising results. So like the executive leadership, just the change in the energy of the frontline staff in this area, whenever you come to somebody and you're like, we've got this new training that we want you to do, or we've got this new thing that we want you to do, you can meet a lot of resistance, but I think people really felt the need and really felt like this was something that could help them and the patients and the families. And then, I don't think at the beginning of this, we expected such transformational change, but it has truly been transformational. We've got new positions, a new internal structure, and changes in practice. And so while we have learned a lot, next slide, please, that has not come without its challenges, right? So communication across a large organization, communication across a small organization is really challenging, and that is ongoing. The importance of face-to-face communication whenever you can, but we know that finding the time for that is also really challenging. But if you can do it, you can really engage in those conversations in a way that you can't necessarily do through email. It's challenging to build allies. So if you're already doing, suicide related work, you really still do need to identify allies and build relationships to ensure that you're building upon what you're doing and use it as a model. So just identifying who those other folks are out there who you can partner with is again, that can be a challenge because again, we all work in silos and we don't always know what everybody is doing. Balance and compromise, you're not going to get everything that you want. And so just sort of know that from the get-go, but do make the goal to be moving forward. Dedicated staff to lead and drive the work. I think it was challenging for folks to find the time, but people were really dedicated and they did. That doesn't mean that it wasn't a challenge though. Also just, increased volume. We're talking about, more kids walking through the door and, trying to support staff who are already burned out. I mean, COVID has evolved from its emergency state, but we've got a healthcare workforce that's still tired and still catching up, and understandably so. Understanding that the organization does have a bottom line. So, again, that kind of goes back to the balance and compromise. And then, the challenges of those external reporting requirements. So these can actually be helpful because you can use it as a way to encourage folks to be reporting in a certain way, but also trying to align what those are, because they're all similar, but a little bit different. So again, hours upon hours of conversation around how to make sure we're appropriately reporting to all of our external entities. And so we will wrap up with our next steps. And so as we continue to move forward, we are aiming to keep the momentum going. We have ongoing training and support, ongoing monitoring and quality improvement through our dashboard, developing a robust research agenda, continuing our expansion of behavioral health services and supports across the system, everything from the EC to specialty care to primary care, and then community building through coalitions so that we can really strengthen those community connections. And we really and truly are working along the full continuum of care. So with that, we will wrap up and open it up for questions. We thank you all so much for your time. I can see there is one question in the Q&A box, and it is about the graph showing the onset of social media over time. So it says, with the graph showing the correlation of the social media emergence with suicide rate, how do you propose it will relate to causation of the higher suicide ideation rates? I would hypothesize that overall, we would see that these are correlated, right? The more social media you are using, the higher that is, the more suicidal ideation we see. However, I want to be really careful, because what we don't know is how individuals are using social media. And so I do think it is very nuanced, because while, many of us lose, how many hours have you lost scrolling and liking, and maybe you share and maybe you post, but there are also, particularly youth, but there are people who are able to seek out communities and find connection and find support through these social media platforms that they aren't necessarily able to find in person. So I think that it's an important work that needs to be done. And I think we have a lot to learn around that. Let's see, this says, I would guess that some of the significant response from your staff was because of not only professional experiences, but personal. So self, family, their own children, particularly in an increasingly challenging environment. Absolutely. Do you have any sense of how much that type of personal experience drove participation? It's hard to be untouched by this issue personally in some area of one's life anymore.
Yeah, I can certainly answer that. I had kind of actually was surprised to see a really balanced level. We had a lot of staff that had recently been impacted with suicide and instantly reached out to us and says, I want to help. But the reality is that grief, or that the struggles that they were having were too active and present, and as much as we allowed them in, we also allowed them to take their time and their space and made sure that we provided them support along the way. We had another group of people that had experienced suicide, either maybe a friend in high school or somebody in their family member died of suicide. And so that's what drove them to come into this work. But we also had staff who had little, if any, experience with suicide. And so that really drew, but they were so passionate about this topic. It just hurt them so much that there are people in this world that are struggling and want to end their life, that's why they got into supporting us. So it really kind of was a balanced approach. We really were very thoughtful, though, of those people who were still actively grieving, still actively struggling with their suicide and grief. And so we had to really have a strong partnership with our EAP resources so that we could get those individuals connected instantly as they move forward.
Let's see, we have another question. How does clinical services reimbursement factor into the ability to be successful? I know there are limited clinical resources, especially compared to the increasing need, but reimbursement for that care that is available seems like it has to continue to be limiting.
And you are 100% right in that. And I don't think we could do the work that we do if it wasn't for our philanthropy partners. They have done a tremendous job at bringing in donors to help address this this issue. I think, though, too, I cannot speak volumes enough about our clinical leaders, and especially our physician in chief for psychiatry and our psychology, who are often, after working a long day at work, going out to donor meetings and going out to dinners and doing and giving talks about the importance of this work. Some of the other pieces that we have been doing is really taking me or some of my my public health team members. We are going out into some of those donor meetings as well. A lot of times they want an experience around it. They want to know that they're doing something. And so we would create an activity that they could do that was helping some of our vulnerable families, but then also too, we were providing talk and resources, and that really helped launch a lot of those philanthropic efforts.
Let's see here. Okay, we have another one. As a parent of a neurodivergent and LGBTQ plus child who is already at high risk, thank you so much for doing this. I hope your work serves as a model, especially across the states with different perspectives on such support. I'm curious how any efforts to communicate with different facilities and different locales has gone. Diane, have you experienced different levels of reception as you continue to go from clinic to clinic in the community?
Yes. So a lot of we are going to different agencies. We are talking to different schools. This is really happening through our community work. That is like, we are well connected with people at the state level and working through that. We are also, the state of Texas has a mental health consortium. And so we are partnering with all of those partners, our mental health authorities, and we are all trying to work together to make sure that we are supporting that work. Our organization, our executives, our leadership is working with a lot of various other organizations through the nation, through CHA and all those different elements to be able to highlight and work collaboratively as a nation over this mental health crisis. But thank you, and best of luck to your child.
And thank you all. We're getting some thanks here. Thank you all for being here.
Yes.
We really appreciate you sharing your time with us. We know your time is limited. We know your time is precious. And, we thank you for spending it with us today.
Yeah, and I would like to thank our speakers today. Thank everyone in attendance for being here. As I said, the continuing education information was put into the chat and also sent to the email announcement. The Preventive Medicine Grand Rounds will be taking a 6-month pause. Our next Grand Rounds, Preventive Medicine Grand Rounds, will be in June 2024. So you can look for the announcement about that Preventive Medicine Grand Rounds then. Again, thank you everyone for attending today. Thank you for our speakers.
Thank you. And someone asked if the resources will be available to us. If you can email Lillian or email us, we can reach out to you.